we'll see what happens. Okay. So quickly, and you're going to get this in CPR, so I'm only going to spend a few minutes on it. But the 5 elements in the chain of survival: it's immediate recognition and activation of the EMS system by the bystanders. Early CPR, okay. Then where we come in primarily is rapid defibrillation, because most people don't have a defibrillator in their house. Now, if they're at the, the store or the bar or something like that, there might be one on site, and hopefully there's trained people there to use that. Then effective advanced life support, and then if we get them back, what do we do with them now? Okay, and that's above us for sure. And that takes teamwork and coordination. So early CPR increases survival chances significantly, and there's study after study after study that shows that. Okay, and compression only CPR is effective. You don't have to do mouth to mouth, because if somebody collapses, they've been breathing up until they collapsed. There's still oxygen in that bloodstream. Okay, so right now when we give pre-arrival instructions as a dispatcher, we're telling them just do compression only CPR. You as an EMT are not expected to do mouth to mouth. Now, yeah, they teach it in CPR classes, but when you're functioning as an EMT, you are not expected to do mouth to mouth. You're going to use a bag valve mask. Okay, infection control reasons. The problem with the bag valve mask is we tend to overinflate. We tend to put too much air and oxygen, because we're using oxygen into our bag valve mask. We only want to put in enough air to make the chest start to rise. If we give full-blown big breaths, that does a couple things. One, there's a really good chance that some of that air, that volume that we're putting in, is going to go down the esophagus and into the stomach. And then they're going to start bloating up their stomach with air. Then what happens? They throw up, and we don't want that. The other thing that happens is if we put too much air in, and it's going, even if it's going in the lungs, we're increasing intrathoracic pressure, increasing the pressure inside our thorax, our chest. Thorax is chest, right? So when we increase that pressure, it decreases the ability of our CPR to pump blood through the arteries, because there's more pressure on those arteries than we really need. So we want to have just enough to cause slight chest rise to get some oxygen in the bloodstream, okay? But not enough to put more pressure in the chest that's going to retard the blood flow from our CPR. Because remember, when you're doing CPR, it's only about 30% effective at best of what the heart would normally be doing on its own. So we want to decrease that intrathoracic pressure. We want to give them some oxygen, but don't overinflate them. So again, the sooner a defibrillator arrives, the more likely the patient will survive cardiac arrest, because, again, sudden cardiac arrest, the most common rhythm that they are in is in that ventricular tachycardia. Ventricular fibrillation. Tachycardia is not all that common, but it happens. So defibrillation, because we're going after that ventricular fibrillation, so we want to defibrillate them. We want to stop the bag of worms. We want to start getting a coordinated heartbeat somehow, okay? So what we're doing by passing an electric current through these people, we're going to put patches on, and we're going to push buttons, and it's going to send a shock through from one pad to the other. What we're looking to do is not jumpstart the heart. What we're looking to do is to cancel out all of those other little impulses that are causing all the muscles to contract, get them all to stop by putting a big shock through there. And then the hope is the SA node will kick back in and cause a coordinated heartbeat, or some place a little further down the line, because remember, anywhere down the line can start the heartbeat. We want to get rid of all that chaotic muscle contractions from all those little extra electrical stimuli. So we're not adding electricity to the heart. We're not jump starting it. We're trying to cancel out all that other chaotic stuff. And so the heart would hopefully come back with a coordinated rhythm. Okay, organized rhythm. Here's a picture of, there's a lot of different defibrillators out there, but they all function pretty much the same. We have one style of cardiac science ones that you'll be using tomorrow. All right. So part of the chain is advanced life support. So if we go on a call as an EMT and we're doing CPR, we're bagging somebody, we're going to apply these patches and plug it into our AED machine, and we shock somebody. If we get a rhythm back, we want to get going. Okay. Whenever we call for a paramedic intercept, we never want to wait on scene for them to arrive. We want to rendezvous with them, get them close to the patient, closer to that advanced life support. And sometimes your closest advanced life support is the hospital. You know, if you're in, you're in Celeron and the closest medic is, medic 73 in Mayville, you're not sitting on scene waiting for medic 73 to come from Mayville. You go to the hospital, that's your closest ALS. Okay, get them there. Oh, I just said that. So the big thing for us in the link, the chain of survival, is early CPR. So we want to start it as soon as we get there if it's not already ongoing. We find a lot of bystanders are hesitant to do CPR. I've coached people at 911 over the phone to do it. And sometimes they start out, but then they just got to stop because it's a loved one and they're having a problem. We hope they continue it, but it doesn't always happen. But early CPR, and it has to be high quality CPR. They're going to talk about that when you guys take CPR, if you're taking it here on the 26th at All-Star, or if you're taking it somewhere else. And then rapid defibrillation. The more time goes by, the less oxygen's in that heart muscle, and the chance of bringing them back with defibrillation starts going away. Because eventually the fibrillation that's happening gets less and less and less until they almost get into that asystole, the flat line. And we can't shock flat line because it's not going to cancel out the chaotic impulses that are there, because there aren't any impulses. And we're not adding electricity to the heart.
Hey, Ron.
Yes.
Not that it really pertains to this, but in the fire hall in Lilydale, they wanted to know if anybody can go to that CPR class or if it's just for our class.
It's just for our class.
Okay, thanks.
Yep, they made a special arrangement with Laura Logan, actually. You probably know her because she's in Casadega.
Mm-hmm.
I think. Yeah, she's in Casadega.
Okay.
To teach the class.
Okay, thanks.
Yep. All right. Yeah, and that's why everybody had to sign up ahead of time so they knew who to get and what they had to do. All right, so rapid defibrillation is our thing. So here's a defibrillator over here. There's patches. We're still going to be doing CPR while we apply the patches, okay? And then plug it in. There's a cord coming from the patches that plugs into the AED. And then we go through the cycle. It'll actually read the rhythm and then tell us whether or not we want to shock if it's a semi-automatic. So you're going to perform CPR. Make sure you're taking precautions. Don't do mouth to mouth. Use an automated external defibrillator. Request ALS. Okay. Again, bag valve mask. You may have to move patients. Lots of times they're like on a bed or on a couch or something like that. You need to get them to the floor. You need to get them to a hard surface. Okay. I've gone to calls where they're doing CPR in a bed. Doesn't do a darn thing. I've gone to nursing homes where they're doing CPR with a patient in a bed. They're just bouncing. They're just bouncing. They're not doing any compressing of the chest at all. Got to get them to the floor carefully because, again, they're limp. And you don't want to bong their head on the floor when you're getting them out of the bed in front of the family. I've done that. It's not a good thing. You may probably going to have to suction because when they're in a rest, all their muscles relax, including esophageal muscles, gastric muscles, and they're laying down, so they might start having puke coming up. So you're going to probably have to suction. And you may have to turn them on their side first and then use suction, depending on how much is there. You're going to use an airway adjunct, oropharyngeal airway or nasopharyngeal airway. As you're starting to do stuff, either you or a partner try to find out from the family, how did this happen? Okay, how long have they been down? Did you go to the store and came back and find them this way? Or did they collapse in front of you? Okay, that sort of a thing. We do have protocols nowadays to stop resuscitation, stop CPR, but we really need a medic there for that. And there's a certain period of time where the medic does certain things, because the medic's going to do the exact same things they do in the hospital in the initial part of cardiac arrest management. The hospital, the only time they do something different is when we get a pulse back, and then they can start doing that post-resuscitation care. But in the first few minutes, I go to a class to learn something called advanced cardiac life support as a paramedic, and I'm sitting next to a doctor who's taking that same class. Okay, and we have to take it every 2 years. So we're doing the same thing as paramedics that they would do in the emergency room. So
I might have missed it, but what does the PRN stand for?
Oh, very good question. I even had a note here to remind myself to tell you guys that. It stands for as needed. And it's some Latin, it's pro nata, something like that. I forget exactly what it is. I don't know. I can look it up. But PRN just means as needed. So you're not going to suction everybody. If there's no secretions in the airway, there's no need to suction. But you need to have suction ready, because now we're going to start pumping on somebody's chest. And if we do get some air in their stomach with the bag valve mask, and they start puking on us, and again, there's no retching in these situations. It just starts flowing. Okay, there's no, there's none of that, because they're not awake. It just starts flowing out. So great question. Thanks for that. Actually, pro re nata. I had to look it up. I've always known what it meant, but I didn't know what the Latin was. So, but here, what you need to know, it means as needed.
Helped us both. I thought I missed it because Daisy was barking, but.
Nope, you didn't miss it. I just forgot it.
Okay.
So yeah, try to find out how long they've been down, because medic shows up and you can say, hey, they didn't see this guy awake for 15 minutes before we got here, and then we started CPR. They're going to start an IV. They're going to give some medications. They may put in a breathing tube. They may shock some more if required. Depending upon what rhythm they're in, they might be in a different rhythm that they can do various medications, try to snap them out of that rhythm. There's a certain period of time, at least 20 minutes of working them, that if we're not getting anything back, we can stop resuscitation. We have orders for that, but most of the time we're calling the hospital or whoever our online medical control is, saying, hey, we've got Joe Blow, 78-year-old guy, cardiac history. We've been doing CPR on him for 25 minutes. We've done this, and that. We're not getting any response, and the doctor would say, okay, quit. Alrighty, because the last thing we want to do is go 90 miles an hour to a hospital with somebody who's basically dead, not going to come back, and get ourselves in an accident. Okay, taking them to the hospital is not going to change anything if they're not coming back for us. If we can get them back, that's a different story. So there's two types of AEDs. The one pretty much everybody uses and I think should use is semi-automatic. In this situation, the AED has a voice prompt that says, deliver shock. And so that shock is not delivered until you push a button. In a fully automatic machine, it says, stand back, don't touch the patient. And it'll say, shock's advised, stand clear. And if you don't stand clear, you're still touching the patient, or it's taking you a minute to get out of that confined space where you're at. If you're touching the patient's leg, it's going to go ahead and shock. So a fully automatic is not the greatest thing. You want one that tells you it's okay to shock, and then you look and say, is everybody clear? I'm clear, you're clear, we're all clear. And then 1, 2, 3 shock type of thing. Because again, you can get shocked from somebody that's getting shocked. The other thing that happens is when you shock them, it causes muscle contraction, sometimes in their arms and legs. And so if you're straddling somebody, and it's happened to me, that's why I'm telling you, I was not touching the patient, but I was straddling him on my knees because I'd stopped compressions, and they went ahead, we had manual defibrillator, and we still do. And the guy shocked him, and his arm came up and hit me right in the crotch. Okay, so you want to make sure you're clear, okay? Things could happen. And you might think, oh, I got shocked. No, it's his arm got me. So semi-automatic is the way to go if you're ever in a position to purchase an AED, get a semi-automatic.
And I have a quick question.
Sure.
So when you have a patient in the back of an ambulance and you're shocking them in the ambulance, do you touch the stretcher too, or just the patient? Because I remember my first time, I was like completely spread out, and my arms were like completely away because I didn't even want to touch a stretcher. I didn't know.
As long as the patient's not touching the metal, you're okay. But if the patient's touching the metal, don't touch the metal. You really don't even want to shock them if they're touching the metal. Actually, I have a slide for that, I think. There's a couple times when we don't shock. When they're in arrest from serious trauma, because it's not going to work. We don't shock them when they're very wet. If they're laying in a puddle, nope. And we don't shock them if they're touching metal. So you want to make sure they're not touching the side rails of your stretcher, okay? Just because it can travel. Most of the time the shock goes right from pad to pad, but sometimes it goes across the surface of the chest because maybe your pads aren't in the best position. But the rules are not when they're really wet and not when they're touching metal, okay? So again, it analyzes cardiac rhythm and determines if it's either that ventricular fibrillation or ventricular tachycardia. So the most common conditions resulting in cardiac arrest are those two rhythms, okay, from sudden cardiac arrest. Now, if it's a patient has multiple medical problems and is, home on hospice or something, or almost on hospice, they could have something else going on and their initial rhythm is flatline, okay? But we're talking about people who are up and about and also keeled over type of thing. So ventricular fibrillation is the most common, and then ventricular tachycardia also happens. So fibrillation and tachycardia. We want to keep doing CPR and only interrupt it when absolutely necessary, for a very, very short period. So you continue doing CPR while your partners are putting on the patches, okay? And up until the point where you tell the defibrillator to analyze the rhythm. Okay, so then when it's analyzing the rhythm, everybody back off, don't touch the patient. So part of the scenario that you're going to have when it comes to the exams at the end is you have to verify pulselessness. Okay, again, 10 seconds. And just real quick, because I'm stealing their thunder, you're going to bare the patient's chest, got a lot of hair, shave it. A lot of agencies where they put the AED pads inside the machine, there's a pouch or something, they put a razor in there, okay? So it goes in the upper right chest, lower left ribs, and then follow the prompts that the machine tells you. Really, really simple. Okay, so CPR while we set up the AED. So if it says deliver a shock and you push the button, deliver a shock, you immediately go back to CPR. You don't try to do a pulse check or anything. Go right back to CPR. And you're going to do 2 minutes or 5 cycles, okay? And then you can analyze the rhythm again. Unless the patient wakes up, moves, or begins to breathe, basically showing signs of life. You go right back to CPR unless there's some immediate signs of life. Now, you're not going to shock them and they're going to wake up and say, hey, it's not going to be that quick, okay? They've been insulted. Their brain's gone without sufficient oxygen for a while, okay? It's going to take them a little bit to come to. But if you start seeing some, agonal respirations, the barely breathing type things, okay, that might be a time for a pulse check. So if the AED finds no shockable rhythm, you go right back to CPR. It's either PEA or asystole. If we get some signs of life, obtain vital signs, in this case, high concentration oxygen, non-rebreather, and get going, okay? Okay, don't touch patient when it's analyzing the rhythm. We never ever apply an AED to a conscious patient to start with. And the reason for that is that ventricular tachycardia can cause a pulse, as I mentioned earlier. So if you put an AED on somebody because you think you might have to use it and it reads VT, it's going to shock this guy even though he's awake. That's not what we want, because then you will put him into ventricular fibrillation. So an AED initially is only applied to an unconscious patient. Okay, unconscious patient. Preferably one that with no pulse and not breathing, because that's when it's really going to be used. If you've shocked somebody and then they come to, or they start showing signs of life, you can leave the pads on because they may go back into cardiac arrest. You may have to shock them again. I ran a call one time. It was a transfer. We had a mobile intensive care unit, we called ourselves way back in the day. And myself and the nurse, we picked up, and a driver, we picked a patient up at Cuba Hospital on east of Olean. And it was to go to Rochester, and it was a guy, cardiac patient, had a lot of issues. And we were probably on the road for about 20 minutes, and he goes into cardiac arrest. It's like, oh, great, you know. So I shock him, and he comes right back. Great. About a minute later, he goes back into cardiac arrest. And I shock him again, and he comes back. 32 times I shocked this guy. And we're hollering at the driver, just find us a hospital anywhere, you know. And by the time we got to the next hospital, like Wellsville or somewhere. And we ran strips because they're called manual defibrillators instead of these AEDs. And we counted out 32 times I shocked this guy. And he survived. He got sent to Rochester like 3 days later from that other hospital. Got a letter from him. Okay, so we don't apply an AED to somebody that's conscious, period. Unless they've come to after being in cardiac arrest, they can stay on. Make sure everybody is clear before you deliver a shock, okay? Very, very important. Again, no soaking wet patients. Do not defibrillate patients touching anything metallic that other people are touching for sure. Some people that have cardiac history, most of them take the nitroglycerin under their tongue, but some take it as a paste. It comes in a tube, and they have a piece of paper that's graduated. It'll say, you know, 1/2 inch, 1 inch, 1.5 inches, 2 inches, that sort of thing. And they lay out a layer of this paste on the paper, and then they slap the paper onto their chest. And it's something they do basically every day type of thing. So it's a continuous medication instead of just taking sublingual when you need it. If they've got one of those patches on, take it, make sure you get gloves on, take it off and wipe that stuff off their chest, because anything, again, it's wet and moist and it could cause arcing. And the last thing we want to do is burn that patient's chest. Some people have implanted devices like a pacemaker. So, and you'll see that lump in their upper chest. It's usually in the upper chest. Just don't put a pad over top of it, okay? But you can, even though they have that pacemaker, you can still defibrillate them. Some people have internal defibrillators. They're called automatic internal cardio defibrillators, AICDs. You're not going to necessarily know that they have one unless the bystanders tell you. We do get calls for patients that say their internal defibrillator's been firing. Fine. You're not going to get shocked by that patient. The current that's going through the heart is very, very minimal from the internal defibrillators because they don't have all the, you know, the skin and the muscles and the bones to send that electric shock through. It's patches sewn onto the pericardium. Remember the sac around the heart, pericardium? And so the voltage that's going through between those two patches is very minimal. It's not going to extend to you touching that patient. Again, their arm might jerk a little bit type of thing, but it's so small amount of energy, you don't have to worry about it. And those people aren't usually in cardiac arrest because they have a defibrillator already. It's taking care of the problem, but they could go into arrest because of other heart disease issues. All right, so that's a bit on defibrillation. So again, cardiac compromise or acute coronary syndrome can have a lot of different presentations. Again, could be MI, could be just angina, could be congestive heart failure, a variety of things. And again, the congestive heart failure, remember, causes pulmonary edema. So they could have swelling in their lungs, causing gurgling sounds or crackling sounds. They could have right side failure, that we mentioned before. They could have that pedal edema, sacral edema, things like that. So if you have a cardiac patient and you don't necessarily have to do a full-blown head to toe, This would be one of those, because they're conscious. Remember, in our assessment algorithm, we have responsive medical patient. But keep in mind that you may want to check their feet to see if they're swollen. You're going to listen to lung sounds to see if they sound, we call it wet, you know, the crackles or, you know, popping sounds or gurgly sounds, things like that. So it would be a focused exam, but thinking about what can happen to a cardiac patient, and make sure you're assessing those parts of the body. Okay. I'm not saying you got to go touch the head and all that stuff, because you see it, they're conscious and whatever, but you might want to look at their feet, a cardiac patient. So again, somewhere around 10% or more of patients don't have any chest discomfort. Females quite often have an atypical response. They don't necessarily have chest pain. People of color sometimes don't necessarily have chest pain. So 90% do, 90%, a lot of them, one of the big problems with a true cardiac patient is denial. No, I'm not having a heart attack. So let me sit down, I'll be better in a minute. You know, it was the taco I ate, that sort of thing. And then they collapse because of the denial. Any questions on cardiac related stuff? How did I do my time? Oh, not bad, just a little over an hour. Trying to shorten them for you guys a little bit. Any questions? All right, so tomorrow night, and if you haven't already from that last recorded lecture, make sure you click on the YouTube video that talks about IM injections, because we're gonna just have you do a couple with the pads. I'm not gonna go through the whole thing, but you need to know how to find the spot in the deltoid if you're gonna have to give intramuscular epinephrine. Okay, so make sure you review that. Nurses, you don't have to, obviously. No questions? No? All right, I guess we're good for tonight, guys. Thank you for watching. Looks like those of you that have your cameras on did not fall asleep, so that's a good thing. All right, I'm going to stop recording and we'll see what happens. I'm wondering if it has a feature that goes back to the start of the session, or if it just starts when I click start. It's probably when I just click start, I'm guessing. So you're only going to get the cardiac arrest portions of it, probably. Okie doke. All right, everybody, have a good night.